Hello friends, welcome to Shri Netralaya. In this video, I will be showing a case of Toric IOL implantation in a grade 2 cataract. This is a very simple case and the case started with a very well dilated pupil in a grade 2 cataract under topical anesthesia. First thing, I am having a marking of 0-180 in place so that I can have a good orientation of Toric IOL. I have already marked 0-180 degrees on the slit lamp, and to have a better visualization and as I can lose the ink marks, I usually do a small epithelial scratch on the cornea. This is a very superficial scratch mark and do not cut the cornea, and the visibility you can see is very nice. The orientation can be well arranged and it is a very small thin line. Anterior capsule is stained with trypan blue and washed away after 20 to 30 seconds. Trypan blue usually takes 30 seconds to have a very good stain. Anterior chamber is filled up with viscoelastic. Now I have a remaining air bubble in the anterior chamber which can be taken out with the help of 27 gauge cannula with 2 ml syringe. This is a real time surgery and not edited one. This is a 5.5 mm Rexis marker which guides me to have a fair idea of CCC to be performed. CCC start with a cystitome needle and moves anti-clockwise. You note the movement of the hand and the flap folded each time separately so that there is no chance of running away of this Rexis. Hydro procedures done with the help of 27 gauge cannula and hydrodelineation also performed. You can see a well golden ring. A nucleus sustainer goes in and I am performing a mechanical chop here to save some amount of ultrasonic energy to be delivered to the endothelium and cause further damage. Once the 4 pieces are performed, it is very easy to remove this nucleus out. You can note how easily the 4 pieces are ready to be taken away with a ultrasonic probe. Cortical material is taken out so that I have better visibility of these 4 pieces, and 1 piece is taken out separately with a very little amount of ultrasonic energy, and this way I can save a lot of ultrasonic energy to be delivered into the anterior chamber and to the endothelium. This makes surgery further better. You can note how easily the nucleus is taken out and epinuclear piece also taken out with the help of handpiece itself in a foot pedal position 2. Anterior chamber is formed with viscoelastic. Irrigation aspiration is performed with coaxial IA probe which is bent. The sweeping side to side movement of this coaxial IA probe make it easy to take more chunk of cortical material, and it can take out the cortical material within seconds. Anterior chamber is again formed with the viscoelastic, and here comes the loading of IOL. In this case, I am using a biotech acryl Toric IOL implant, which is monofocal, and the cartridge is closed loop. Both the haptics of the IOL are folded after having a visco injected into the cartridge, and the cartridge is attached to an injector system, and the IOL is implanted directly in the bag with the help of pusher. Once the IOL is inside, it is dialed in position. Here the targeted implantation is 180 degree. Visco is taken out with the help of coaxial IA again, and in toric IOL cases it is good idea to wash the visco even below the IOL so that the IOL rotation chances goes down. This IOL is quite stable in a post-op period, and my marks on epithelial area is helping me to keep the IOL in position. So this was a demonstration of a grade 2 phacoemulsification with toric IOL implantation in bag, and the procedure is complete. Hope this simple video will help you, and each step will guide you to have better handling of the cases in your OR. Do subscribe to a YouTube channel Dr. Pankaj Lande for such videos. Thank you and good day.